Petro Katerina is a distinguished guest from Cedars-Sinai from the US. He's going to talk to us about cardiothoracic transplantation across the pond.
Thank you very much, Speed, and thank you for inviting me to give this talk. I'm delighted to see so many people in the audience for a transplantation talk, and I'm especially delighted to see my former colleague and our incoming president here for this session. So for those of you who don't know me, I worked my whole career in the UK. I was at Papworth for 12 years as a consultant, and then in 2020, I left the UK to take a job in the United States, so where I've been for the last 5 years. And so I think I'm in a good position to give this talk. I have no disclosures. I'm certainly not in a unique position. And, this slide is a collection of surgeons who've moved from the UK to the US just in transplantation. I haven't included surgeons in the other fields, of which there's a steady trickle. But maybe I can just highlight a few individuals. First of all, Asghar Kagani, who is the surgeon in the top left, who was the director of transplantation at Harefield for a long time, and was said to be the surgeon who had done the most heart transplants himself. He moved to Michigan and started a program there very much from scratch, and is still very much revered today for having started that program. That was about 12 years ago, and then there was a gap. And then Ayaz Ali was the first of the sort of new generation of movers, and he moved from Papworth to Yale, and he increased the number of heart transplants by 400%. And so, British surgeons really had this great reputation in the US, and then they started to attract other people. And there are 3 center directors who have moved from the UK in the last 2 years, so that reflects the amount of experience that's losing from the UK to the US, and also 2 surgeons there who moved from the National Organ Retrieval Service to work for a commercial organization in the US doing retrievals. But obviously the grass isn't entirely greener on the other side, because these are my colleagues from Papworth overwhelmingly, and I know that they have had people trying to attract them abroad and have not gone, and so clearly the grass isn't completely greener. And as we know, Asghar Kagani did come back to the UK to help Bart set up their LVAD program. So what I'm going to try and give you is an idea of what the current situation of thoracic transplantation is in the UK and the US, give you some donor data for the US and how transplantation is organized. And maybe you can draw your own lessons from that. So the first thing to say is that there's a big difference in numbers. So the US is a leader in heart transplantation worldwide, doing more than 13 per million population. And in the UK, the number's around 3. So essentially per population, the US does 4 times as many transplants. And the situation in lungs is the same. The US isn't quite the world leader in that, but it still does 9 per million. In the UK, it's between 2 and 3 per million, but it's essentially 4 times the number. And part of this is down to donors. So you see the countries that are very dark blue are the ones that have a really high rate of donors, deceased organ donors, and that's, you've got Spain, very much a world leader, and the US also in the dark blue, UK a little bit behind. And if we look at actually the number of deceased donors in the UK, it's 21 per million population, and about half of those are DCD, and that really complicates things a little bit for thoracic transplantation, mainly pushes up the costs. In the US, the numbers are doubled, so 42 per million population. And if you compare that with Spain, which is the leaders, it's around 50 per million population. And you can see that DCD, which was never very common in the US, has really increased quite a bit, is now a third of the donors. So that's the donor situation. And then how about the sort of recipient outcome situation? So this is a slide from the UK. If you just look at the 2016-2018 cohort, for which I have comparable data, you see 1-year survival for heart transplant in the UK is 84%, 5-year survival 75%. So the comparable cohort in the US, The 1-year survival is over 91%, the 5-year survival 80%. So really able to achieve excellent outcomes. And then for lungs, the similar numbers, 83% 1-year survival for lungs, 55% 5-year survival in that 2016-2018 cohort, and 89% 1-year survival in the UK, 60% in the US. And, you know, one of the big factors is, of course, not only do we have more donors in the US, but we have these sort of donors, which I irritate my colleague, Maris Berman, by sending him pictures of, because, and I obviously couldn't show hearts because, you know, you can't really see the difference to heart, but you can see that these are all young, healthy lungs. And why is that? I mean, it's really sad, but we have all these reasons for deceased donation, which you don't have in the UK. You know, we have this fentanyl crisis, a lot of gunshot injuries. Half of the gunshot injuries are actually suicide, but nevertheless, it's a big factor that you just don't see in the UK. And then they drive these enormous vehicles. This is the Ford F-150, the most common car in the US is that car. Can you believe it? But also, on the other hand, apart from this, the consent rates in the US are really high. And I was quite surprised at that because I think that the consent rates reflect the cohesion, the solidarity that a society feels. And but I have to tell you, the consent rates are higher than in the UK. So what about the system? So it's outsourced. It's got this name UNOS, and you think, well, that must be a government organization. It's not. The government tenders a contract for private companies to run transplantation, and the contract has been won pretty much every year by this company, the United Network for Organ Sharing. And they have a base, which is in Baltimore. They have a lot of facilities, and they run the allocation system, and they run the waiting list, and they do divide the country up into different regions where there are slightly different rules. But every donor that you get is offered to you electronically, and the recipients are ranked from 1 to 10,000, and the offer is made to individual recipients. So there's no ability for the transplant center to say, oh, yeah, I'll take the organ, but I'll use it for this person lower down the list. Each offer is for an individual recipient. You have to accept or reject it. And this computer interface also allows you to see all the imaging that's relevant, and even allows you to ask questions and ask for manipulations to the donor. And below UNOS, so UNOS is the equivalent of NHSBT. Below UNOS, there are these organ procurement organizations, which are also private organizations, but they're not-for-profit. And each state probably will have at least one. California, a big state, has got 4. They run the practicalities of the donation system in the US. So they employ the people that here are the specialist nurses in organ donation, or they have the clinical leads for organ donation. Those sort of individuals work for these organizations called OPOs. And then you have the transplant hospitals, and there's no regulation in the way there is here, where there are a fixed number of hospitals that are allowed to do transplant. In 2024, there were 135 hospitals in the US doing adult heart transplantation, and their numbers varied from 1 to 162. And you can see that even in pediatrics, there were 54 centers doing pediatric heart transplant. And the numbers in lungs are not as big, but actually the numbers are growing. And many, many of these centers do just 1 to 5 transplants. But it may be that these transplants are what keeps those centers financially viable. And that is why there is this enormous spread. And there are some positives on the donation side. So the picture on the left is your typical team that goes out for an organ procurement. There's a surgeon and a transplant practitioner. There's no scrub nurse, there's no assistant. Of course, many times we have medical students who want to go, and they augment that team. But it's a very streamlined team. That's the equipment they take, 1 cooler box to bring the organ back in, and that has the perfusion fluids in it. and then one bag with specialist equipment like staplers. Everything else is provided on site. I'm going to call it scrub tech, but the person who does the theater nurse is provided by the local hospital. And of course, the distances are bigger, so you end up a lot of times on aeroplanes and helicopters. But I think that is one positive there. It's quite a streamlined procurement team. And then the people. So I think that this is really what makes the grass greener. So this individual is my right, left hand, everything. Marion is a nurse practitioner who is has a PhD. She worked for Tyrone David for many years, so she's a very experienced aortic nurse practitioner. She looks after all my patients. So my typical clinic is that I'm sitting in my office doing admin, and Marion sees the patient, gets all the data together, and then she gives me a call, says, patient's ready. I go to the clinic. She presents the patient to me, shows me all the imaging. I go in, speak to the patient, discuss an operation, and then go back to my office. And Marion documents the encounter. And that is the best thing about the United States. But it's a lesson that I think the UK could learn about. So you know, I mean, it really values my time, and it values the time that I spend with the patient, in that it's a discussion about the key elements. It's not asking them about their allergies and whether they smoked in 1952 and, you know, that sort of thing. She deals with all that. And generally, there's a high level of administrative support. You know, so I have a secretary, I have somebody who organizes my theater booking and makes sure the patient comes in and has everything sorted for that, and somebody else who organizes my clinic booking. So there is a lot of staff. That I don't think is a terribly positive thing. And then this, yeah, of course, it comes down to the people. I had to put up all the slides I've shown have had a lot of men in them, just to show you we do employ women in thoracic transplantation in the US. This is an entirely female heart transplant team, not at my center, but at one of the nearby centers. And then, so, okay, what are the less green bits? Well, I'm on call a lot. So there are just 2 of us doing lung transplant in my center. So that means I do 15 nights of lung transplant call. And then there are 6 of us doing heart transplant call. So I do 3 nights of heart transplant call. And then I do 5 nights for general adult. But it doesn't feel quite as busy as in the UK. And my wife reports that there are less phone calls in the night than that we used to have. And perhaps part of that is due to the donor on call. The first line is actually the physician. So there's a transplant cardiologist receiving the heart offers, or there's a transplant pulmonologist receiving the lung offers. And then this was my operative practice in 2024. It's quite a bit less than I was doing in the UK. In the UK, I did 200 to 250 cases. I know that was before COVID, and I know generally numbers have come down. But last year in the US, I did 140 cases, and that was the sort of breakdown. It's a lot of lung transplants and then some other stuff, mainly aortic, more complicated aortic work. Hardly any what you probably call bread and butter cardiac surgery. I did 1 coronary artery bypass graft in 2024. And this is another good thing about the US. This slide is to remind me that, so it enormously irritated me in the UK that to do a lung transplant, I had to come in at, 1 a.m. and do a briefing. I'd do my briefing at 1 a.m. and then they would bring the patient in, line them up, start anesthesia, and then I would come back at 3 a.m., having sat around for 2 hours, to start the lung transplant operation, which many of you know is a long operation, and then I would carry on and maybe finish the operation at 2 p.m., having seen a couple of different teams come through. So I don't have to do a briefing. I get to arrive with the patient prepped and ready to have incision made, and at that point there is a WHO timeout. But it is about valuing the time of the surgeon. Well, at the bottom line is that how green you see one side or the other really depends on what you're looking for. And all these decisions about moving are, they're 100% personal. But the grass will be greener where you water it. And that applies to all the bits of the transplant process, not just the operation itself, which I think a lot of people focus on, the whole donor process and then the evaluation and listing. And then I think this is my final slide. So apart from, I've said all these things, and life's really tough in the NHS, tough in the UK, but the biggest improvement, the biggest jump forward in heart transplantation since cyclosporin, which cyclosporin is like 1980, was DCD heart transplantation. And where did DCD heart transplantation come? It came from the UK. So the biggest advance really came in a situation where donor numbers were down, resources were stressed, and that inspired, the creativity of the gentlemen you see up there, two of whom are in the audience, who really sparked what is in the US an explosion of DCD heart transplantation. It's now a third of our activity, and coming up to 1,000 cases a year. And then, so that's on the left-hand side. On the right-hand side, that's Dr. Kenny, I believe, from Newcastle, who is a pediatric cardiac surgeon and who is pioneering using hypothermic oxygenated perfusion for tiny hearts to allow babies to be transplanted. So also a great development from the UK. So thank you very much for your attention. And that's it.